Hello, and welcome to day 2. Yesterday, we heard opening statements from the plaintiff and the defense. And today, the plaintiff's case will be presented, and the defense will have an opportunity to cross-examine the witnesses. You will hear from the patient's wife, Rachel Paulson, the inpatient floor resident, Dr. Jamie Miller, the floor nurse, Carrie Anderson, the inpatient attending, Dr. Thomas Kendrick, and the plaintiff's expert ED witness, Dr. Kelly Lennon. I will now turn it over to Judge Reynolds to begin day 2 of the mock trial.
Good morning, ladies and gentlemen. Counsel, would you please call your first witness?
Your Honor, the plaintiffs will call the plaintiff, Rachel Paulson. Good morning, Ms. Paulson. The jury's already been introduced to you, but for the record, can you tell us your full name and your relationship to Mike?
Sure. My name is Rachel Paulson, and my husband was Mike Paulson.
And how long had you and Mike been married?
About 5 years.
Had you ever been married before?
No, I'd never been married before. Mike and I met in high school and dated throughout college.
Did you and Mike have any children?
We did not have any children. Our plan was to start trying the year he passed.
You said that Mike went to engineering school. Tell us about that.
He was a senior VP with Whiting Turner, and he was hired right after school and worked his way up to be the VP. He was the second youngest in the company history.
I want to ask you a little bit about Mike's going to the emergency room on April 22nd and then being admitted to the hospital the following day, the 23rd, 2023. Tell me a little bit about where Mike was that day.
It was a Saturday, a weekend, and Mike had gone to the gym earlier in the day before I woke up.
Okay. And were you there when Mike got back from the gym?
Yes, that was his usual routine.
Okay. You tell the jury what, if anything, you can recall once Mike got home.
He got home around 9, and he complained that he had a ripping pain in his chest that went through him towards his back. I remember him saying the words ripping because it seemed kind of strange.
Okay. And how did you respond? What did you guys do next?
His pain continued to get worse, and he said he couldn't take it anymore. He wasn't really a complainer, so I started to get worried, and we went to the hospital. I had to drive him.
You took him to the hospital. What did you do when you got there?
We parked and walked into the emergency room.
Okay. So you were with Mike when he got into the emergency room?
Yes, I stayed with him until he was admitted. But then visiting hours were over.
So tell me a little bit about what happened when Mike arrived at the emergency room.
When he arrived, he was seen by, I think, a nurse. He described that ripping pain in his chest and that it was going towards his back. They asked a bunch of questions, but I specifically remember him telling her both of those things about the ripping pain towards his chest because it was just a strange description to use.
How was Mike behaving at that time?
He was very loud, which was out of character for him, but I guess it was because he was in incredible pain. And we were both getting a little anxious and maybe a little bit annoyed because it just didn't seem like people were really paying attention to us. And it just seemed to go on. And and he was in so much pain. The longer he was there, the more pain he was in.
What do you mean the more he was there, the longer he was there, the more pain he was in?
We were in the ED for hours and he kept just saying that his pain was getting worse.
Do you know whether in the emergency room, Mike told any of the providers, any of the doctors, nurses, that his pain was getting worse?
Yes, he definitely did. I was sitting next to his bed when the nurse came in, and he said that his pain was a 10 out of 10 at that time.
And then Mike was ultimately seen by a provider?
Yes, he did see the doctor at some point, but I don't remember him seeing him again after that.
Okay. And then did they do any tests?
Yes, they did an ultrasound. I don't remember what the results were, and some other tests, but I'm not quite sure what they were or if we were told about them.
Okay. And around that time, the physician did see him, correct?
Yes, a female doctor. She said that Mike was going to be admitted to do some monitoring and more testing, but I don't recall what they said they were going to do.
When she said that Mike was going to be admitted, did the doctor tell you or express to you or Mike that his condition was critical or it was urgent or?
No, I thought this was routine testing and it was all just being done out of precaution.
While you were in the emergency room, did any of the providers or the doctors tell you that they suspected that Mike may have an aortic dissection?
No, I've never heard that word before until Mike passed away and after his death.
When Mike got admitted to the hospital, did you stay with him?
I was there most of the day until the visiting hours were over.
Tell me what you can remember about him being admitted to the hospital.
He was in a lot of pain, and he was telling anyone who came into his room that he was in pain. I know that he at one point went for a CT scan, but I don't remember what the results of that were.
Okay. While you were with him, did a doctor ever come see Mike?
Not while I was there. It was usually just a nurse, but she was reassuring that she was in contact with the doctor and that the doctor was aware of the things that were happening.
When was the last time you saw Mike?
Right when the visiting hours ended, I left and I thought I would see him in the morning.
Did you see him in the morning?
No, that was the last time I saw him. We didn't get to say much of a goodbye, but we said we would call each other in the morning.
How did you come to learn that Mike had passed away?
In the middle of the night, that night, I got a phone call that Mike had experienced an event and became unconscious. They said that they tried to resuscitate him, but they couldn't, and he passed away.
You okay, Miss Paulson?
Yes, thank you. I was in shock. I had just seen him a few hours earlier.
I know this may be difficult for you to express, but can you tell the jury what Mike's passing has done to you?
He is the love of my life. We were high school sweethearts. We had been together our entire lives. We were planning on starting a family and growing old together, but that's not going to happen. He was also the primary breadwinner for our family. I work, but his job paid the majority of our bills and our mortgage. I'm not really sure how I'm going to move forward with anything in our life at this point. Everything's changed, and I don't really know where to start or how to start it up again.
Thank you very much, Ms. Paulson. No more questions.
Thank you, Ms. Paulson. We have no questions for the witness, Your Honor.
Your Honor, the plaintiffs will call the defendant, Dr. Jamie Miller. Good morning, Dr. Miller. Can you please state your full name and business address for the jury?
Dr. Jamie Miller, 22 Green Street, Baltimore, Maryland, 21202.
Okay. And what's your occupation?
I'm an attending internal medicine physician at the University of Maryland Medical System.
Were you an attending physician in April 2023?
No, in April 2023, I was in my final year of residency. I've since completed training and stayed on as an attending at UMMS.
Do you have any memory of caring for Mr. Paulson?
No.
You have no memory of a patient who was screaming in pain and later died from an aortic dissection?
Objection.
Sustained.
Doctor, since you can't remember my client, Mike Paulson, have you had an opportunity to at least review his medical record?
Yes.
Is it your understanding, based on your review of that record, that you were the resident who admitted Mr. Paulson from the emergency room to the hospital?
Yes, that is my understanding.
And based on your review of the medical records, what was Mr. Paulson's admitting diagnosis?
He had back pain with a suspected gallbladder etiology based on ultrasound testing done in the ED. The ED providers also considered aortic dissection, but ruled it out based on the patient's age and lack of risk factors.
Would you have authored a note in the record?
I did, as the resident who admitted the patient.
Actually, instead of authoring a record, what you really did was just simply cut and paste the note that had been previously written by the emergency room doctor, didn't you?
Correct.
And in fact, that note that you cut it and pasted did not actually include any new findings or information that was reported by Mr. Paulson when he presented to the medical floor, correct?
Correct.
So any new information such as a family history or his current condition was not included in the medical record?
Correct.
Well, doctor, you'll agree with me, though, that the medical record should be as accurate as possible to ensure that the healthcare providers reading that record have all the information necessary to them to treat their patients.
Yes, to the extent possible, you always want the medical record to be recorded as current as possible.
Okay. And when information is provided and it's available, you enter it in the medical record for that reason, correct?
That's correct.
And in fact, here, there was critical information that you didn't include in Mr. Paulson's medical record because you had simply cut it and pasted the emergency room record.
I'm not sure I agree with that.
Well, we see in a nursing note that Mr. Paulson had a family member who died of an aortic dissection at 45 years of age, correct?
Correct.
But that was not included in your note in the medical record because you simply cut it and pasted the note from the emergency room.
It was not included in my note. That is correct.
And that family history that Mr. Paulson had a relative who also died from an aortic dissection at a young age is certainly information that a physician, like your attending physician, would want to know when they were evaluating the patient, correct?
It could be relevant, yes.
And you didn't share that information with the attending physician in Mr. Paulson's case, did you?
I do not recall, but I probably did.
It's not documented in the medical record.
No, it is not.
I want to turn issues a little bit, doctor. Based on your review of the record, did there come a time when one of the nurses assigned to Mr. Paulson sent you a Tiger Connect message regarding Message Paulson?
Yes, she did. Her message was actually added to the medical record, which isn't usually done. So I was able to see the Tiger Connect message that she sent.
Okay. You were able to see it in the medical record when you reviewed it for this case, correct?
Yes.
Okay.
She stated that the patient had a 10 out of 10 pain that was not controlled with medication and that his blood pressure was dropping.
And we can agree that those are concerning findings.
They can be.
Mr. Paulson's blood pressure dropping is certainly a concern, and it's a new finding from the emergency room vital signs that were taken, correct?
Yes, his dropping blood pressure would be a concern.
Yet you didn't do anything about those concerning findings, did you?
The Tiger message the nurse sent was very long and contained way too much information. When we are busy, it's hard to take the relevant information when we receive messages that are so long. The blood pressure information was buried in the message, and I've come to learn that we were also in the middle of responding to a code on another patient. If she had written the message better, I might have seen it more easily. On my review, I am sure that I did not realize the patient's blood pressure had become low, seeing the way the message was written.
I have no more questions, Your Honor.
Dr. Miller, are you saying that this was the nurse's fault?
That's not what I'm saying. It was relevant information and it was provided by the nurse. I was actively involved in a code situation, trying to save another patient's life at the same time I received it. My plan was to see the patient as soon as I was able.
Thank you, doctor. I have no further questions.
Your Honor, the plaintiffs will call Nurse Carrie Anderson. Nurse Anderson, can you please provide your full name and business address for the jury?
Carrie Anderson, 22 Green Street, Baltimore, Maryland, 21202.
And what is your occupation?
I am a medical IMC nurse at UMMS.
And did you hold that position in April 2023?
Yes,
In April 2023, how long had you been a nurse?
4 years.
And those 4 years, were you working your entire career at the University of Maryland?
Yes.
Nurse Anderson, do you have a memory of my client, Mike Paulson?
I have a general memory of Mr. Paulson.
And tell me what you remember about him.
I remember that his wife was there with him and he was in a lot of pain despite the medications that he was on. I remember sending a tiger message to the resident because his blood pressure was dropping. And I remember that he didn't look great, which is another reason why I sent the tiger message.
Okay. Let me ask you a little bit about some of those things in your answer there. You mentioned Tiger Connect. Have you had an opportunity to review the Tiger Connect message you sent?
Yes.
First, let me ask you this. Can you explain for the jury what is Tiger Connect?
Sure. It's an internal messaging system similar to sending a text message, but it's HIPAA compliant.
So it's basically a text message that shows up on the recipient's phone?
Yes.
Am I correct that the Tiger Connect messages are not intended to be part of the medical record?
Correct. It's so the providers can message each other when direct communication might not be immediately possible.
But it's certainly not meant to replace direct communication.
That is correct.
And we can agree, nurse, that direct interaction is the best way to communicate with providers, especially when there's important information that needs to be conveyed.
Objection?
I'm going to overrule that objection.
In circumstances, yes.
Direct communication allows the providers to interact with each other and convey, kind of express the importance of the information they're trying to convey, right?
Yes.
And by having direct communications, if there's a question about the information that's being conveyed, the person's in front of you and you can ask them that.
That's correct.
Now, you testified that Tiger Connect was not part of the medical record, correct?
Correct.
Now, here, you took a screenshot of the Tiger Connect message you sent and you put it in the medical record, though, right?
Yes, I did.
Have you done that before?
Yes, I routinely add messages to the medical record.
Is adding Tiger Connect messages to the medical record against University of Maryland policy?
I'm not sure, but I feel like it's a good way to document what I've communicated to the medical team, especially when I'm worried about a patient.
And in this case, you wrote to Dr. Miller what's been described as a very long message. Do you generally write lengthy messages to the providers?
It depends, but oftentimes I do.
And why is that?
Well, the residents are very busy, and I try to include as much information as possible into one message so that I don't have to interrupt them and repeatedly message them.
You would agree, however, that the more information that you put in a Tiger Connect message makes it more likely the person receiving the message might miss a piece of information in that text message.
I guess that's possible, but I assume that the residents are reading the messages in the same way that they would read the information in the chart.
Now, the message you sent, in this case, one of the things you mentioned remembering about Mr. Paulson was that he didn't look great while you were caring for him. Do you remember telling me that?
Yes.
And let me ask you a little bit about that. What do you mean by not looking great?
Well, his appearance was changing and he seemed like he had gotten paler, and I was also concerned about his changing vital signs because his blood pressure dropped, and that was a new finding from the emergency department.
So why didn't you follow up with the resident about these concerning findings?
She responded to the Tiger message and ordered Dilaudid and said that she would come see the patient later. So I assumed she reviewed my message in its entirety and had formulated a plan based off of it.
So you Tiger Connect messaged a resident, but you could have actually gone personally to a fellow or an attending with your concerns, couldn't you?
Yes, there's always an attending available, and I believe a fellow was available as well.
Okay. So there were more senior physicians available to you to go to with these concerning findings from Mr. Paulson.
Yes.
So if you had these concerns, why didn't you raise them with one of these providers?
Well, I received the resident's response to my message, and I relied on her judgment and management plan.
I have no further questions, Your Honor.
Thank you, Your Honor. We have no questions for Nurse Anderson at this time.
Your Honor, the plaintiff will call to the stand Dr. Thomas Kendrick. Good afternoon, Dr. Kendrick. Could you please state your full name and business address for the jury?
Sure. Dr. Thomas Kendrick, 22 Green Street, Baltimore, Maryland.
Dr. Kendrick, what is your occupation?
I'm the attending physician on the medical IMC.
Okay. Was that your position in April 2023?
That is correct.
Doctor, we're here because of the care and treatment provided to my client, Michael Paulson, who was a patient of yours back in 2023 in April, correct?
Correct.
Do you have any memory of caring for Mr. Paulson?
No.
Have you had an opportunity to review Mr. Paulson's medical records?
Yes, I have reviewed it.
Okay. So based on those medical records, what's your understanding of the care provided to Mr. Paulson?
I was the attending who was providing care for Mr. Paulson on April 23rd, 22nd, and the 23rd.
And Mr. Paulson came from the emergency room. Would there have been a patient handoff at the time you assumed care for Mr. Paulson?
Yes, there would have been a handoff from the ED team. I would have reviewed the medical record, and I would have received information from the resident that was working with our team on that day.
Okay. So based on your review of the medical records, when Mr. Paulson arrived, what was the working diagnosis of his complaints?
The patient had significant back pain. The working etiology was that he had some kind of a gallbladder disease based on ultrasound that was done in the ED, or perhaps sport-related injury because the onset was immediately after he had a workout session.
Do you have any memory of caring for Mr. Paulson that day or night?
I do not.
Based on the medical records, did you ever perform an evaluation of Mr. Paulson?
Yes, it looked like I saw the patient before going home that day.
Okay, and what was your evaluation at that time?
I noted that the patient was in significant pain, and he was not really cooperative with my evaluation.
Was Mr. Paulson being uncooperative because of the amount of pain he was in?
I do not recall.
Okay. What was your assessment and plan for Mr. Paulson following your examination?
I felt like the current diagnosis and plan was appropriate.
Did you review the medical record as part of your examination?
I would have, yes.
Okay. Did the medical record that you reviewed at the time include information provided by Mr. Paulson that he had had a family history of an aortic dissection? A family member had died at the age of 45 from that.
No, that was information that was not available to me at the time.
Okay. You've since learned, come to learn that Mr. Paulson did report that family history when he was admitted to the floor, though, correct?
Yes, that's my understanding now.
Okay. And we can agree that knowing Mr. Paulson had a family history of an aortic dissection would be an important piece of information that you would want to know when you're examining him and directing his care and treatment.
Yes.
Can we agree that had you known that information, in fact, your care and treatment of him would have been different?
I cannot say whether my treatment would have been different had I known that information. I may have other additional testing, perhaps a CTA, but I cannot say what I would have done sitting here today.
Are you aware that Mr. Paulson's condition was changing after you went home? Specifically, his blood pressure lowered significantly.
Yes, that was my understanding.
You were aware of his blood pressures at that time?
I do not believe I was.
Okay. Can we agree that had you known of that information about his blood pressure dropping, that would have also changed or altered how you examined and directed your care and treatment for Mr. Paulson?
Again, I cannot say I would have done what I would have done 2 years ago sitting here today, other than I would have had all the taken all that information into account to develop my treatment plan.
Doctor, based on your review of Mr. Paulson's records, did any of the providers ever consider an aortic dissection was the cause of his complaints?
Yes, I believe it was one of the things considered by the ED team.
And the ED ruled out an aortic dissection based on Mr. Paulson's age and lack of risk factors, correct?
That's what the record indicates.
Okay. But a family history of aortic dissection is one of those risk factors, no?
Yes, that's one of them.
Okay. And although young, Mr. Paulson was 30, his family member was 45 who had an aortic dissection. That's young for both of them are considered young, correct?
Somewhat, yes. Mr. Paulson was 30, and I believe he reported a family member was 45.
So we can agree that both of the reasons why an aortic dissection was ruled out in Mr. Paulson's case turned out to be incorrect.
Yes.
And in fact, that information that was available to you as a provider at the time, but it wasn't included in the residence note when you did your evaluation.
That's my understanding.
Now, that information about those risk factors was in the nursing note. Did you review the nursing note at the time you were evaluating Mr. Paulson?
I do not recall, but it's not my usual practice to review nursing notes in detail, since any critical information would have been escalated to the medical team by the nurse.
I have no further questions, Your Honor.
Dr. Kendrick, thank you. Your Honor, we have no questions for the witness at this time.
Your Honor, at this time, the plaintiffs will call Dr. Kelly Lennon. Good afternoon, Dr. Lennon. Dr. Lennon, you're an emergency room physician, correct?
Yes, that's true.
And you're currently the chairman of the Department of Emergency Medicine at Brigham and Women's Hospital in Boston, Massachusetts.
Yes.
Okay. And that's affiliated with Harvard Medical School, where you're a professor.
Yes.
And you've been practicing emergency medicine for over 30 years.
Yes.
Can you tell the jury a little bit about what your role as an emergency medicine physician entails?
Sure. In my role, I see and treat my own patients in the emergency department. I also oversee a team of residents, which means that I'm able to teach and guide them throughout their graduate school experience to foster them into attendings.
And prior to teaching and doing that at Harvard, you were actually a professor of medicine and taught emergency medicine at Johns Hopkins University here in Baltimore, correct?
Yes, that's correct.
Have you served on the boards of any medical societies or journals?
Yes, the editorial board of the New England Journal of Medicine.
And how about textbooks? Have you served on the boards of any medical society or journal? Excuse me. Have you been involved with the review of any publications of medical textbooks?
Yes, Rosen's.
Let me ask you about when you were at Johns Hopkins. I think it was from 1997 to 2004. Can you tell the jury what your work at Hopkins during that time was?
Similar to what I'm doing now, I had my own practice of patients in the emergency room, and I oversaw a team of residents, which means that I taught them and guided them throughout their experience to go on to be emergency medicine attendings.
Okay. And I think we've already talked about you left Hopkins to basically take the same role at Brigham and Women's Hospital, where you've continued to work until today, correct?
Yes, that's correct.
You, I think, talked a little bit about your teaching practice and teaching residents, but tell me a little bit about your clinical practice. You've mentioned your own patients a lot.
Sure. I work in a busy, fast-paced emergency room, caring for patients with a variety of diagnoses. In my role as an attending, I work closely with the residents.
And doctor, you're board certified in emergency medicine, correct?
Yes, that's correct.
And you're also familiar with the term standard of care?
Yes.
Tell the jury what you understand the term standard of care to mean.
The standard of care is what a reasonably competent person would do under the same or similar circumstances.
And are you familiar with the standard of care expected of an emergency medicine physician providing emergency medical care in a hospital emergency department?
I am.
In the course of your work as an emergency medicine provider, have you had occasion to provide care for patients who have arrived complaining of chest and back pain?
Yes.
And in your course as being an emergency medical provider, are you familiar with what the standard of care requires in diagnosing and treating those patients who arrive in the emergency room?
Yes.
Okay. And you're also familiar with the standard of care in diagnosing and treating patients who come to the emergency room with an aortic dissection?
Yes, that's correct.
Dr. Lennon, at my request, you reviewed the medical records of my client, Michael Paulson, regarding the care he received at the University of Maryland on April 22nd and 23rd, 2023, correct?
I did.
Okay. Can you tell us what records did you review?
I reviewed the entire medical chart from that admission, starting with the initial ED presentation throughout the hospitalization and through Mr. Paulson's death.
Dr. Lennon, based on your review of those materials as well as your background training and experience, have you reached an opinion regarding whether the care provided to Mr. Paulson while he was a patient at the University of Maryland on those days, April 22nd and April 23rd, 2023, complied with the applicable standard of care?
I have.
Okay. And what is that opinion, doctor?
It is my opinion that the healthcare providers did not meet the standard of care, resulting in Mr. Paulson's death.
Okay. And is that an opinion you hold to a reasonable degree of medical certainty, doctor?
I do.
Dr. Lennon, I'd like you to describe to the jury your opinion to a reasonable degree of medical certainty how those healthcare providers violated the standard of care.
There were multiple breaches in the standard of care. First, the emergency providers improperly ruled out the aortic dissection based purely on the patient's age and lack of risk factors alone. Mr. Paulson's severe and worsening back pain, as well as his description of chest pain with ripping as a description, were all red flags of aortic dissection. The emergency room physicians failed to affirmatively rule out aortic dissection by ordering a CTA of the chest and/or a transesophageal echocardiogram, referred to as a TEE. Ideally, both of these would have been ordered, but either one or the other would have revealed the aortic dissection that was present when Mr. Paulson presented to the emergency room.
Let me stop you right there, doctor, and ask you, had the emergency room providers ordered either a CTA or a TEE, as you have opined was required by the standard of care, do you hold an opinion to a reasonable degree of medical certainty whether that would have detected the aortic dissection and allowed for the providers to timely treat Mr. Paulson and prevent his death?
Yes, had either of those tests been performed, the aortic dissection would have been identified. An aortic dissection is a medical emergency. Medications would have been given immediately, and likely a surgical consult would have been obtained and likely progressed to surgery. University of Maryland is an exemplary institution similar to Harvard, where I practice. These interventions would have been obtained quickly and prevented Mr. Paulson's death.
Dr. Lennon, based on your review of Mr. Paulson's medical records, were you able to identify any other breaches in the standard of care by any of the other providers at the University of Maryland during April 22nd and April 23rd, 2023?
Yes, there were clear communication breakdowns between the entire healthcare team, and that likewise resulted in misdiagnosis of the aortic dissection and, unfortunately, Mr. Paulson's death.
Doctor, can you explain to the jury what you mean?
Sure. First, for some reason, the emergency room attending, Dr. Timmons, did not review the nursing note reporting the ripping chest pain as described and severe back pain. It's unclear to me why she failed to do so, and as these are cardinal classic signs of aortic dissection and would have presumably affected her diagnosis and treatment. Instead, they just ordered an ultrasound and got stuck on gallbladder diagnosis.
Okay. Anything else?
Second, the resident who admitted Mr. Paulson to the floor was given new information by Mr. Paulson that there was a family history of aortic dissection, and apparently in a relative that was similar in age to Mr. Paulson. This information, however, did not get transferred into the chart by the resident. It was simply cut and pasted, and the note was never put into the emergency room record, which did not contain the additional information. I appreciate that residents are very busy, but failing to include these vital facts clearly affected the later provider's decision-making.
Anything else, Dr. Lennon?
Yes, as a matter of fact, the bedside nurse reported to the resident that the patient's blood pressure was dropping, and she said that she felt he was unwell, but did nothing further to escalate this. That resident never saw the patient, and the nurse failed to bring her concerns to the attending.
Do you have an opinion to a reasonable degree of medical certainty whether Mr. Paulson had been accurately diagnosed with an aortic dissection and received timely treatment, whether his death could have been prevented?
Yes, I believe that he would have survived had the emergency room physician, Dr. Timmons, reviewed the nursing note stating gripping chest pain. The aortic dissection would have been on the top of the differential diagnosis. Similarly, had the resident recorded the family history of aortic dissection, and subsequent providers would have taken that into account when they were determining what tests needed to be ordered and further care needed to be provided. Additionally, the aortic dissection was only taken off the differential diagnosis based on a lack of risk factors, which was not the case once that information became available from the resident. Unfortunately, that information was never communicated, and it resulted in continued misdiagnosis of Mr. Paulson's straight through, leading to his death. Had the resident who had evaluated Mr. Paulson had this information, the same treatment plan that was available in the emergency room could have been initiated and still prevented his death at that time.
Thank you, Dr. Lennon. Please answer any questions Mr. Brady may have for you.
Dr. Lennon, you're not an expert in hospital communication or medical record keeping, are you?
Yes, that's correct.
And you've never been qualified as an expert by any court in either of those specialties, correct?
Correct, I have not.
In fact, you were not offered in this case as an expert in those specialties, correct?
Correct.
Now, I understand that it's your opinion that the standard of care required Dr. Timmons to order a CTA or a TEE, correct?
Yes, that's correct.
And we can agree, Dr. Lennon, that many patients present to the emergency department every day with complaints of chest and back pain.
Yes, that is a common complaint that we see.
And we can also agree that the standard of care does not require every one of those patients who present with chest and back pain every day to get either a CTA or a TEE, correct?
Correct, yes. Those studies are not ordered based on complaints alone, which is why it would have been important for Dr. Timmons to have reviewed the nursing note with the gripping chest pain and the severe back pain.
But Dr. Timmons did order testing for Mr. Paulson, correct?
Yes, she did.
She ordered a chest x-ray.
Yes.
And it was normal.
Yes.
She ordered an EKG.
Yes.
And that was normal.
Yes.
And she ordered an ultrasound.
Yes.
And that ultrasound demonstrated gallbladder sludge, correct?
It did.
And you would agree that that finding could have been the cause of Mr. Paulson's pain?
Well, maybe, but not at the level of pain that he was complaining about.
Dr. Lennon, it is also your opinion that had the CTA or a TEE been done in either the ED or after Mr. Paulson was admitted to the hospital floor, it would have demonstrated the aortic dissection and treatment would have been initiated that would have prevented his death. Did I hear your testimony correctly?
Yes, that's my opinion.
And you testified that treatment would have included surgery, correct?
Yes, that is correct.
And that surgery would have been done by a cardiothoracic surgeon, is that right?
Yes,
And you, doctor, are not a cardiothoracic surgeon, are you?
that is correct.
And you've never performed the type of surgery that Mr. Paulson would have undergone.
Correct.
Thank you, doctor. I have no further questions.
Thank you.
Dr. Lennon, in your more than 30 years of experience as an attending emergency room physician, both at Johns Hopkins and at Brigham and Women's, have you had an occasion to treat patients who are diagnosed with an aortic dissection?
Yes, hundreds.
And the testimony that you provided earlier regarding the type of care Mr. Paulson would have received had his symptoms been appropriately and timely diagnosed, as well as the timing of the care he would have received, is that based on your experience with that patient population?
Yes, based on that, my experience, my training, and my medical knowledge, in addition to working in an institution that is very similar to University of Maryland with very similar resources.
Thank you. No further questions, Your Honor. Your Honor, the plaintiff rests this case at this time.
You probably noticed that defense counsel did not cross-examine the decedent's wife today. In reality, defense counsel may or may not have cross-examined her as the plaintiff, depending on whether there was anything to drill down on related to her memory of what occurred in the hospital. Defense counsel has the opportunity to cross-examine in order to clarify something said by one of the clinicians, or defense counsel has the option to reserve their questions for the defense case. Today, you heard about a few of the stumbling blocks that can make this case harder to defend. Let's talk about them. Looking at the patient's behavior in the ED when he was yelling and being aggressive with the team in this case is portrayed by the plaintiff as staying away from the patient and as a result missing a key part of his family medical history and missing the diagnosis of aortic dissection. The patient here is shown by the plaintiff to be acting out because of the amount of pain he was in. The healthcare team endures significant disrespect and abuse by some patients, but there are times when clinical symptoms can be a contributing factor to the patient's behavior. As noted yesterday, encountering rudeness may also have the effect of inadvertently narrowing one's clinical perspective. Use of copy and paste function in the electronic medical record was discussed. In this circumstance, the medical history from the ED was copied forward, which missed the patient stating once admitted that he has a family history of aortic dissection. This is an important piece of information, and although it was known by the inpatient resident, the documentation makes the care appear sloppy, and as though this important piece of information was overlooked. It also strengthens the argument that the resident was encountering a type of cognitive bias and did not give this new fact importance, given that the team was going down the path of evaluating and treating the patient for gallbladder disease. The use of secure messaging system, Tiger, was discussed today as well. The convenient way of communicating in a HIPAA-compliant manner also can lend itself to challenges when not used as intended. In this circumstance, there were lengthy messages exchanged in order to inform the resident of the patient's changing condition. Ideally, Tiger should be used for brief and easy-to-understand messages. In a perfect world, recipients of such messages can take the time to read, interpret, and digest information being sent. But in reality, in a busy clinical environment, messages can easily be missed or misinterpreted. In this case, the resident glancing at the lengthy message while leading a code was a recipe to miss the important information about the patient's decreasing blood pressure. The nurse also copied and pasted the Tiger message itself in the medical record. It could easily be assumed that the content is appropriate for placing in the medical record, but UMMS policies make clear that Tiger messages are not part of the medical record and should not be placed as such. Communication through Tiger must always be professional, but senders and recipients do not intend for their messages to be placed in the record, nor should they be. The proper thing to do is to document separately in the EMR about the patient's condition, communication, and plan without a copy or screenshot of the Tiger message. Here, the pasted Tiger message makes it seem that the resident was aware of the blood pressure and perhaps ignored it, when in reality, she had not effectively become aware. Tomorrow is day 3 of our mock trial, and it will be the defense turn to present its case.